Welcome to Authors at Google. I'm Rebecca Moore, and I'm privileged to introduce our speaker, Dr. Victoria Sweet, who's going to talk about her new book, God's Hotel, A Doctor, a Hospital, and a Pilgrimage to the Heart of Medicine. The book launched just 1 month ago, and I think as Googlers, we can relate to working long and hard on something, maybe for more than a year. You're passionate about it, you launch it, and then you wait with some trepidation to see what's going to happen. Well, the great news is that God's Hotel is taking off like a rocket ship, and we're very privileged to have Dr. Sweet with us here to talk about it. In its first week, it made it onto the San Francisco Chronicle bestsellers list. 2 days ago, it was just reviewed by the New York Times Science Times, who called it transcendent and a tour de force. So congratulations on that. Dr. Sweet is both a physician and a prize-winning historian with a PhD in history and social medicine. She's also associate clinical professor of medicine at UC San Francisco, and I'm personally happy to say that she studied mathematics and Greek at Stanford University. Go Stanford. There will be time for Q&A at the end, and Victoria will sign books for those of you who would like them. And finally, just on a personal note, I've known Victoria for many, many years. She has always been someone who was comfortable taking the road less traveled, and I think now with God's Hotel, she has created a whole new road to a place and time that few of us even knew existed. And now she's here to tell us about it. Please welcome Dr. Victoria Sweet.
Is the microphone working? Yes. Well, thank you very much, Rebecca, and thank you all for being here today. And thanks, Google, for letting me speak here. Laguna Honda Hospital was like no hospital I had ever seen or even imagined. I got there kind of accidentally. I had decided to go back to school to get my PhD in medical history after I'd been practicing medicine for many years. And Laguna Honda was the only place that would let me practice medicine part-time. So I went over for my interview. When I saw it for the first time, I was nonplussed. It was high on a hill overlooking the ocean, and it looked like a medieval Romanesque monastery. It had peach-colored walls, a red-tiled roof, a bell tower, and turrets. After my interview, the medical director took me out to show me around. She showed me the long open wards that go all the way back to when monks took care of the sick poor in the monasteries for free. We went upstairs and she showed me the surgery suite, which looks like where Humphrey Bogart had his face redone in Man Without a Face. We walked past the old-fashioned beauty salon with its steel helmet hair dryers. She showed me the library, the auditorium, and the chapel, which was really more like a small church with polished wooden pews, stained glass windows, and the Stations of the Cross along the walls. Then we went out and she showed me the gardens. Turned out that Laguna Honda had been the almshouse for the city, and it was on 62 acres and is still on 62 acres of land in the middle of San Francisco, and the gardens are extensive. She showed me the greenhouse, the aviary, and the little barnyard so that patients could pot plants, watch chickens hatch from eggs, and even see animals even if they were bedbound. Then we walked back to her office and she offered me the job. I didn't know. I wasn't sure. I told her I would come for 2 months, and I stayed for 20 years. It turned out to be a wonderful place to practice medicine. And part of that was the place itself. So the place was a great place to practice medicine in terms of its spaciousness, kind of ramshackle. But what really made it incredible were the patients, because it turns out that Laguna Honda was the almshouse for the original almshouse for the city. And that was how we used to take care of the sick poor. That's how we used to take care of the sick poor before there was health insurance. There would be a free county hospital and a free county almshouse. The acutely ill would be taken care of in the free county almshouse, county hospital. And then when, if they needed additional care or nobody knew what else to do with them, they were transferred to the almshouse. It used to be that every county in the country had a free county hospital and a free county almshouse, and that was how we took care of the sick poor. Starting in the 50s, the almshouses across the United States were closed, and many of the county hospitals, except for San Francisco, which still has its county hospital and still has its almshouse, albeit now called a hospital. So the patients, as you can imagine, are the bottom 0.1% of the population. And what I found is that they were 2 standard deviations from the mean, any mean. So they were the tallest and the shortest, the fattest and the thinnest, the nicest and the meanest of any patients I ever had. And they had every disease too. So they taught me a tremendous amount about medicine and healthcare, cure and caring, efficiency and inefficiency. The 2 months went by, and then a year or two, and I really didn't notice that the years had gone by or that I was learning a lot from the patients until I got to my patient, Mrs. Todd. Ms. Todd was 35 years old. She had cancer. Her cancer was brain cancer, and what made it horrible was that it was just behind her right eye, and it had grown, in spite of surgery and radiation, right out of her eye. The surgeons had removed the eye and sewn the eyelid down over the cancer, but the cancer was still growing. Miss Todd had never been beautiful, but what with the radiation, which had caused her hair to fall out, the steroids, which had caused her face to balloon, and the sewn eyelid, she was very hard to look at. Yet she was pleasant and quiet. She always smiled as I passed her by. Eventually, we were on speaking terms, with a quick hello and how are you from me to her and from her to me. I got used to her deformity, although only by blocking out, in some way, my experience of her experience. One day, I finally braved my reluctance and stopped by her bed, full stop. We looked at each other. She at me, white-coated and rushed, a bit disheveled. I looked only at her left eye. "Is there anything I can do for you?" I asked her after we talked a bit. "Yes," she replied, "there is. I really don't like the food they're giving me. It's all cut up and bland. Do you think it could be changed? And another thing, could you arrange for me to visit the eye doctor? I need a new pair of glasses." I was and am to this day floored by her response. I was and am awestruck by such equanimity. She wanted not euthanasia or a miraculous cure, stronger pain medication or a second opinion, but different food, a pair of glasses. She said nothing about her terrible misfortune. She was calm, matter of fact. Somehow she'd accepted her fate, and it was the small things, the little daily things, that were important to her. We did change her diet, and we did get her new glasses. Not long after, she moved to another ward, and there she died peacefully 18 months later. Ms. Todd capped my experience of those first years at Laguna Honda. She summarized it and hinted at what I would be learning later. Even when there is nothing to do for a patient, no cancer to discover, no paradoxical pulse to take, there is still something to do. It doesn't have to be life-saving, grandiose, and heroic. It can be as simple as a pair of glasses or a different diet. In fact, it usually is. I learned a tremendous amount from the patients at Laguna Honda. If I had to summarize what I learned in one sentence, it would be that the practice of medicine is a personal relationship between doctor and patient. And when it's personal, it works. And the best way, the easiest way I can explain what I mean is to tell you the story of Dr. Curtis and the case of the missing shoes. I learned a lot from Dr. Curtis, but it was with the case of the missing shoes that he taught me the most about care and caring, time and inefficiency. On this particular day, I met him by accident in the wide-windowed corridor that ran the length of the hospital and connected all the wards. He was in a hurry. Where was he going, I asked. Back to the rehabilitation ward, he said, where he was covering for a few weeks. The rehabilitation ward was its own mini hospital within Laguna Honda. It admitted the patients with the milder strokes and the less traumatic head injuries, most of whom would recover and be discharged back to their homes if they had them. Although its patients, too, were often without friends, money, or health insurance. Like the admitting ward, it had its own physicians to admit, examine, and discharge its patients, and this month, Dr. Kirkus was one of them. He just returned from outside the hospital, he told me, and was headed back to a patient who, having been rehabilitated after a stroke, had been ready for discharge for months. But every day when Dr. Kirkus made his rounds, checking on the 36 patients on the ward, this patient was still there, still zipping around in his wheelchair, still going to therapy. Finally, Dr. Kirkus said, I asked him why, since he was able to walk, he was still here. Why was he still in a wheelchair? Why hadn't he been discharged? No shoes, Doc. They ordered me special shoes, but they're waiting for Medicaid to approve them. How long have they been waiting? Dr. Kirkus asked. 3 months. Dr. Kirkus thought a bit. What size shoe do you wear? Size 9. Dr. Kirkus reflected for a while. He thought about his duties, his other patients, the charts he had to dictate, the quality assurance forms he had to fill out. And then he left the hospital, got in his car, and drove to Walmart, where he bought a pair of size 9 running shoes for $16.99. He'd just come back with the shoes and was going over to the ward to put them on the patient and write the discharge orders. Was he planning to submit his receipt for reimbursement, I asked. He laughed. As I watched him hurry back to the rehabilitation ward, I wondered, why had Dr. Kirkus done this? And why hadn't anyone else? It was a simple thing to do, but it never would have occurred to me to do it. I would have been frustrated with the shoe delay, of course, and I would have filled out a second or even a third Medicaid form. I might even have written Medicaid or braved its phone tree to complain about the time that pair of shoes was taking. But it would never have occurred to me to go to Walmart and buy the patient's shoes. I had too much to do, too many forms to fill out, too many other patients to see. It would have meant crossing a kind of inefficiency boundary. And yet Dr. Kirkus got in his car without much questioning and was hurrying back to the ward with the shoes to put them on the patients himself. He reminded me of an aphorism I loved but had never understood. The secret in the care of the patient is in caring for the patient. I'd always assumed that that meant caring about the patient, loving or at least liking the patient. But when I saw Dr. Kirkus rushing off to put shoes on a patient he barely knew, I thought there must be more to it than that. So I tracked down the quote and found it in a talk by Dr. Francis Peabody to the graduating medical class of Harvard in 1927. It turned out that Dr. Peabody didn't mean caring about a patient, but caring for a patient, which he explained meant doing the little things, the little personal things that nurses usually do. Adjusting a patient's bedclothes, giving him sips of water. That took time, Dr. Peabody admitted, and wasn't perhaps the most efficient way for doctors to spend their time. But it was worth it, he told his students, because that kind of time-costly caring was what created the personal relationship between patient and doctor. And that relationship was the secret of healing. In the meantime, let's see, my clicker. In the meantime, I'd started my PhD in medical history, and I was studying the medical writings of Hildegard of Bingen. Hildegard was a 12th century German nun. She was also a visionary, a mystic, a composer, and as it turned out, a medical practitioner, and she'd written a book about her medicine. It was fascinating. It was not the eye of newt, toe of frog medicine I expected from a medieval medical text. It was a real medicine for real patients with real diseases that I could recognize. But it was based on a completely different idea of the body than our mechanical model. Hildegard's idea was that the body was more like a plant than a machine, and the doctor more like a gardener than a mechanic. What's the difference? The difference is that someone has to fix a broken machine. But a plant can heal itself. Hildegard called the power of a plant to heal itself its viriditas, its greening power, from the Latin viridis, meaning green. And she thought that human beings also had viriditas, a natural power of healing, and that the doctor, therefore, should be more like a gardener, cultivating that viriditas, removing obstructions to it, nourishing it, than like a mechanic. I didn't really understand what Hildegard meant by viriditas until my patient, Terry Becker. Terry Becker was one of my bad girls. Actually, the New York Times called her the worst girl, and I thought that was actually a good way to put it. She was homeless and lived on the street with her boyfriend, Mike. And she smoked and drank and used drugs. One day she woke up paralyzed from the neck down. She went to the county hospital, and they discovered that she had a rare viral disease called transverse myelitis that has no treatment, but does tend to get better over time. So they sent her over to Laguna Honda. She was on rehabilitation, and she did pretty well. She started to get better for about the first 2 weeks. But then the first of the month rolled around when the homeless in San Francisco get paid. They get welfare cash, and Mike, her cute boyfriend, showed up, and out they went. She disappeared for about a year. Later, I found out that during that year, she'd been seen in the emergency room, the county, 28 times, and had 3 long admissions to the county, each time, just as she was getting better, going out on the streets. During that time, she developed a bed sore. Mike also robbed her and beat her up. She went back and forth to the county getting very expensive operations to cover the bed sore with a skin graft every time she went out. Finally, the bed sore was too big to graft. The county didn't know what to do, and they sent her over to Laguna Honda for treatment. When I examined her, I was really quite shocked. I mean, she looked pretty sick. She was only 37. And she looked like she was in her 50s at least. It was the bed sore that really shocked me. It was the worst I'd ever seen. It was huge, enormous, and deep. It went from the middle of her back all the way down to her tailbone, and it spanned both of her sit bones. The skin was completely gone, of course, but so were the fat and the muscles that covered the spine. In their place was an unidentifiable mass of decayed and decaying and infected tissue from the failed skin grafts. And at the bottom of this wide, deep hole, I could see bone, Terry's spine. Terry's bed sore was scary. She had no protection. Everything delicate and crucial in her body, bones, kidneys, spinal cord, was exposed and vulnerable to an environment full of germs. Giving antibiotics to try to prevent infection wouldn't work because the bacteria would get resistant to them. And the bed sore really was too big to graft, even if the surgeons agreed. It would have to heal on its own, and that would take years. In the meantime, what chance did Terry have of not getting an overwhelming infection that would kill her? I walked back to our little doctor's office and sat down at my rickety desk. I stared for quite a while at the wooden shelf on which was Mrs. McCoy's robust plant, now grown all over the wall. The bed sore was a catastrophe, and possibly the end of Ms. Terry Becker. For the second time with the patient, I thought about Hildegard, and I asked myself, what would Hildegard do? How would she treat Terry Becker's huge and open wound. What she would do, I suddenly saw, was remove obstructions to Terry's viriditas. Because if nothing was in its way, then viriditas would heal her wound as surely as a plant will grow green. What was in its way, I asked myself. The mass of dead tissue was in its way and needed to be removed. Any pressure on Terry's body, from wrinkled bedclothes to hard mattresses, was in its way and had to be removed. Dirt, unkemptness, stale clothes, unnecessary medications, fear, depression, all were in its way. My first job, therefore, as gardener doctor was not to make a brilliant diagnosis or give any magical medication, but remove obstructions to Terry's own viriditas. It was quite amazing how fast Hildegard's prescription worked. Within a few weeks, I began to see signs of healing deep within Terry's wound. There was no infection, and deep down, at the base of the wound, was it my imagination? There was a smooth and pink glistening, which was starting to cover and protect her spine. But then the first of the month rolled around, and Mike showed up. He was still pretty cute, still wearing his tight Levi's, still walking with a flirtatious though constrained strut. The nurses made him wait in the smoking room, and Terry wheeled herself on her gurney, face down, back covered, the whole length of the ward. Then she rolled into the smoking room. They were in there a long time. Then the door opened, and Mike came out and left. Terry had thrown him out. She told him never to come back. Then she stopped smoking. So her appetite improved and she gained weight. Without nicotine constricting her blood vessels, the tiny new arteries and veins at the base of her bedsore could absorb the vitamins and protein she was eating, and the hole in her backside began to fill in. Since I did not check the bedsore daily but only once a week, its progress seemed as magical to me as one of those time-lapse movies they showed us in school, where a plant grows from a seed in a matter of minutes. Terry's wound began to look like a huge scab. The scab thickened until it was even with the rest of the skin, and then just as petals push against the constriction of the bud and open it, the scab flaked off and there was pink skin underneath. That awful crater filled in from bottom to top and from side to side. It took a long time. It took 2.5 years. But we were in no hurry, and neither was she. Terry changed the way I practiced medicine. After that, I not only looked at patients with the eye of the modern doctor, focusing in on what was wrong with the patient and how I could fix it, but I also stepped back and looked at the patient in the context of his environment and asked myself, is there something I can do to encourage this patient's viriditas? Is there something I can do to remove what's in the way? What I found was that this kind of slow medicine worked very well for patients with slow diseases, diseases that were long in developing, chronic diseases, or for which medicine had no really good treatment. I began to think of it as slow medicine, as opposed to the fast medicine that I also use, which works so well for fast diseases, heart attacks, appendicitis, cancer, but doesn't work so well after the heart attack, the appendectomy, the chemotherapy. Then, about halfway through my time at Laguna Honda, things started to change. There was a big push to turn the old-fashioned hospital into a modern healthcare facility. There was a lot of battles, politics, and struggles, especially between the director of public health, whom I call Dr. Stein in the book, and the doctors, nurses, and administrators at Laguna Honda. Finally, one day, Dr. Stein had had enough, and he replaced the medical director, the nursing director, and the executive administrator all at once with his own picks. They were to come over to the hospital and transform the hospital into a modern facility. The name of the new executive administrator I called Mr. Conley. And this is what happened. Mr. Conley was a bluff, hearty fellow with an energetic, gravelly voice, red hair, and red beard. He reminded me of the youngish Henry VIII around the time he fell in love with Anne Boleyn. And he was, as they said in the Middle Ages, Dr. Stein's man. His orders were to change Laguna Honda from an old-fashioned almshouse to a modern healthcare and rehabilitation facility, and he had been warned by Dr. Stein about the obstructions he would face. The balky doctors, the obstreperous nun, the ex-director of nursing. Mr. Conley was prepared. But Mr. Conley, with the best will in the world, eventually made a fatal mistake. He stepped out of the administration wing and met the patients of Laguna Honda. I don't know how it happened, but I supposed it had to do with the crashing of our computers. Every computer in the hospital and everything about them. Email, printing, all the laboratory data, all the forms. The computers went down and stayed down for months. It was fortunate that the hospital was as big and sloppy as it was, because not everything was on those computers. Most of us still had our books. The telephones were still plugged into the walls. We still had our wooden mailboxes, overhead paging, and clocks. There was no email, however. And so instead of sitting in his re-redecorated administration wing and shooting out electronic missives, Mr. Conley had to scribble his messages on pieces of paper, and when they were important, deliver them himself. Huffing and puffing the whole long length of the hospital, himself praying that the elevator would start and not stop midway, himself praying, passing the tattooed smokers in Harmony Park. Like the rest of us, Mr. Conley fell under Laguna Honda's spell. He began to say hello to the patients he passed. He began to know some of them. He began to visit them in their rooms and on the open wards. And he softened. He got a bit confused. Perhaps there were patients at Laguna Honda and not simply residents. Perhaps Laguna Honda was a hospital and not a healthcare and rehabilitation facility. And so even after the computers were fixed, which took 4 months, and I was surprised at how much less work I had while they were down, even including telephoning the lab for my results, Mr. Conley continued to step out of the administration wing and visit the patients. Not with Miss Lester's compressed mouth and eagle eye, but still he sat on beds, he talked, he listened, and he learned about the hospital from the patient's point of view, which would be fatal. Mr. Conley changed after that. Not so much his decisions, which came down from above, but the way he felt about his decisions, because he knew the patients now, and he knew how his decisions would affect them. And what I learned from that is that it wasn't only medicine that had to be personal. Administration has to be personal, too. Over the past 20 years, I've watched medicine, the pendulum of healthcare swing from the personal to the efficient. And I have been amazed by how inefficient that efficient healthcare has turned out to be. Healthcare costs keep rising astronomically every year. Patients, doctors, and even economists are more and more frustrated. Nobody seems to know what to do. So let me end with showing you what happened when modern, efficient healthcare landed at Laguna Honda. What I did is I put together a graph over the 20 years I was at Laguna Honda. As cost-cutting measures, the patients were gradually whittled down by about 40%, from 1,178 to 780. The doctors were also whittled down from about 32 to 9, so about by 80%. And the clinical staff was whittled down by about 30%. But the budget kept rising. What's more, the total staff stayed the same. Why was that? We kept having more and more administration and management. In fact, by the time I left, the day I left, I looked around and realized that there were more quality assurance managers at Laguna Honda than there were doctors. That was pretty scary. What does all this new management do? It's hard to know for sure, but the one thing there are more of at Laguna Honda today than when I started there is forms. When I first got to Laguna Honda, there were 2 forms of 1 page each. The day before I left, I took out a random chart, opened it up, and counted. There were 43 forms, and most of them were 3, 5, 10 pages long. I made a rather complicated scribbled graph of this, but I think it's worthwhile looking at it. I don't have a little pointer, so you'll just have to follow me, but you can see the patients in the blue in the middle are going down, 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 down. The doctors, the physicians in the black, going down, down, down. The budget is going, that blue line that just goes up. And the forms, which is the red line, going way up. And I've actually pulled this out to, assuming that the present trends continue, in 2024, if they continue, there will be no patients at Laguna Honda. 2 physicians, 1,400 FTE, and a budget of $280 million. I think it's time for us to all work together to give that pendulum of healthcare a nudge backwards, towards the inefficient, the human, and the personal. Thank you very much.
I had a question about the bad girl patient.
Yes.
What exactly was it that sort of helped her to turn around her life and break free of her abusive, exploitative boyfriend?
Yeah.
Yeah. What is it about the care she received, or was it something that she just had reached a point where she knew it was either death or completely transform her life? Or
it's a great question.
Any
Can
idea?
everybody hear that? Good. Okay, great. I think that's a beautiful question actually to ask. I ask myself that a lot, and I think there are 2 things. That last time, Terry was way at the end of the ward, and she had a very special nursing assistant named Connie. That I'd noticed that Connie's patients always got better. There was just something about Connie. And she was also kind of trapped because she was on that gurney lying down, face down for weeks. And I just think she had some kind of change of heart. It was really very mysterious, change of heart, but that was her true healing. In fact, the name of this chapter I call The Miraculous Healing of Terry Becker. And that, what you put your finger on, is exactly the miracle that she made that decision. And I don't really know why, but I do know that that decision stayed made. And that once she was healed, not only was she healed of her bed sore, but by the time the bed sore was healed, everything else about her was healed. We'd found her family, which hadn't seen her in 10 or 12 years. The family wanted to have her back home with them. We had a patient gift fund at Laguna Honda, so we could get the money together to send her back home. She'd fattened up. She'd had a whole personality change, from irritable, frustrated, and kind of mean, to kind and grateful. She was like a completely different person, and I know that she went back to her home and stayed. Never went back on the streets.
Going off from this last slide,
yes.
What do we do to make that happen?
I don't know quite the answer to that, except I am getting so much attention for this book and these ideas, and I feel a little bit like the kid with the emperor new clothes. I'm like, wait, there's just no clothes here. I mean, come on, people. Like, medicine is personal. Is that like the most unbelievably smart thing you ever heard? No, it's like, hello. And so I'm getting this kind of reaction from people. And I think it's going to make a change. I almost think just by thinking about this, recognizing it, I think it's going to change anyway because, fortunately, we live in a capitalist country. And the fact is not only is it is in fact more efficient. It saves money when the doctor has enough time to do a good job, get the right diagnosis, take you off the medications you don't need. It saves money. And I think once the capitalist health system realizes that it's cheaper to give doctors enough time to see patients than it is to whittle us down so that we just have to order a whole bunch of tests. It will change on its own, I do believe. So I just think there's kind of a will out there, because the doctors are just, they'll love what I'm saying here, and the patients, everybody, it's like a trip.
Curious, did Terry have substance issues and was becoming sober part of her recovery?
Absolutely. Absolutely. But as you probably know, making that decision to become sober, I mean, really it was, when she went in that room, I can remember it right now, we were all just cringing, I mean, this had happened over and over again. We were just sure Mike and she would be rolling out together. And when I saw, it still gives me shivers, when I saw Mike walk out of the door open, and he walks out and he's by himself. And I remember him walking out the ward. We had swinging doors, and he went through the doors, and the swing shut. And then Terry rolled herself out of the room, back to her bed. I was like, wow, something happened there. And then, of course, she did give up smoking. When she gave up smoking, everything just sort of fell into place. But why, I don't know. I don't really know. Yes?
With the popularity of your book, have the decision makers at any other medical facilities reached out to you to learn how they can reproduce the success of your experience?
I'm starting to get a few things like that, but it's really just starting. I'm getting invitations to talk at different places. I've had a few, but I'm actually wanting to get kind of up, like Washington, kind of like level, because the health, huh? Well, I don't know. What about the Surgeon Emperor or something really powerful? Yes, Sandra.
So when I look at the medical profession here, and actually I should just add a footnote. My mother is actually currently in hospital, and she's been in for a couple of weeks and probably be in another week. But I feel very comfortable about that.
Is she here or in Italy?
She's not in America.
Uh-huh.
She's in Italy.
Uh-huh.
So I think she's going to be fine. Well, I mean that seriously, because at any rate, I mean, a lot of that's the talk you're giving here. But one of the issues in America that I see that's very different is everybody seems to want a quick pill fix-it thing, and if they don't get a quick fix-it, they go to the legal system. And so one of the issues that I keep thinking comes up around medicine, why it is the way it is in this country, is a lot around malpractice, financial covering your ass, I mean, a bunch of stuff like that. So if you switch into being more inefficient and human, the doctors are going to have to spend more time with their patients, which means fewer patients. I mean, the whole equation in this country is sort of in one direction, and all of this, I mean, of course, there's that other piece that all too many doctors seem to be kind of focused on the money and not so much on the caring. I mean, certainly that's the stereotype that I see around. And, all these pieces play into an equation, as you're describing, that's around money and efficiency and this and that informs, around covering your ass and covering your pocketbook. So, yeah, I mean, I'd like to know more about,
Well, there are alternatives. I mean, to me, what we need in this country is just like an experiment. Because in a way, Laguna Honda for me was an experiment. And I have many, many cases where it's quite clear that the Laguna Honda treatment, Terry is a perfect example. You could say 2.5 years in the hospital, I mean, that's huge. But before she'd been in the hospital, she'd been going back and forth, getting $100,000 operations back and forth. That was, I mean, you could say, why treat her at all? And that's a different discussion. But if we're going to take care of people, then I was quite sure from what I saw at Laguna Honda that it was cheaper the Laguna Honda way to take the time. And I can give you a very practical example. Doctors are cheap. And one of the things that's happened in this country is the economists, when they were trying to cut costs, they assumed doctors were really expensive. So they've been, de-skilling doctoring onto nursing and nursing onto da-da-da-da-da. But in fact, doctors are quite cheap. I mean, I'm like $100 an hour. If I spend an hour with the patient and that hour allows me not to get an $1,800 MRI, we're way ahead of the game. So I think one place to start is to just have a model and show that. Because if they show that, Kaiser and HMOs and everybody's going to go, well, that's way cheap. We'll just give back to doctors back their time. That is cheaper. In terms of malpractice, of course, there's all that and it's complicated. But I will say this. that the malpractice, what they say is that you do not actually get sued as a physician when you make a mistake. You get sued when the patient feels you didn't care about them. And I have found that to be the case so far. Okay? I really have. So that I think a lot of the malpractice issue is a little bit of a covering. I think we can do this. I think it's going to happen. It actually is happening. Okay. While I was writing this book and kind of coming, this is actually happening because what's happening is doctors are saying they can't take it anymore, and they're doing this concierge, whatever boutique, whatever kind of stupid name they've got for it. This idea that it's more like CSA, like community-sponsored agriculture, where you pay up front, you pay $100 a month or $150 a month, and the doctor gets his patients up front. Instead of having to have 1,000 patients to pay his bills, he doesn't need any back office because he gets paid up front. So he can have 250 patients. And with those 250 patients, he has all the time in the world to take care of you. And so that's actually an experiment, that's sort of a hidden experiment that's going on right now. It's very interesting. The patients are thrilled, the doctors are thrilled. So it's very interesting, yes.
I freely admit that I may not know the facts correctly in this, but I understand that there's something of a shortage of doctors. And if doctors are inexpensive and we should have more of them, is there something we should be doing to foster more doctors being out there so that we can have more slow medicine?
Well, that's kind of a complicated question, and you don't know, and I don't really know, but I think there's two pieces of it. The shortage is in what they like to call primary care doctors. So I'm an internist. I'm like the front person to take care of you. And there's a shortage, there seems to be a shortage. Why? I don't want to do it. I don't want to get an unbelievably complicated patient and have 10 minutes to spend with the patient, of which I spend 3 minutes on the computer. 7 minutes, you can't do it. So what you're having is doctors are not going into primary care. They're going into subspecialties. And if I had a kid who was going into medicine, I would tell them, do not do what I did. You get yourself a nice little specialty where you can do a good job and you can have a satisfying practice. So I think there's plenty of doctors, but they're not going into primary care. So that's one thing. The second thing is my generation of doctors are dropping out of the system like flies. We don't want to. We like taking care of patients. So I think if we could take care of patients the way we wanted, I think it's a little bit, that's my sense, is there's probably plenty of doctors, but shifting who does what is more the issue than educating more docs.